Raynaud's phenomenon and frostbite are conditions that affect the extremities, particularly in response to cold, but they differ significantly in their causes, symptoms, and outcomes. Raynaud's phenomenon 1. Cause. Raynaud's phenomenon is a vasospastic disorder, meaning that the blood vessels, usually in the fingers and toes, constrict excessively in response to cold or stress. 2. Phases. Raynaud's typically involves three color changes: white, pallor. Blood flow to the affected areas decreases, causing the skin to turn white. Blue, cyanosis. Prolonged lack of blood flow leads to a bluish coloration due to oxygen depletion. Red, rubor. When blood flow returns, the skin becomes red, often accompanied by tingling or pain. 3. Triggers. Cold temperatures, emotional stress, or sometimes even holding cold objects can trigger Raynaud's attacks. 4. Duration. Episodes are usually temporary and resolve once the person warms up or the stressor is removed. 5. Risk. Raynaud's usually doesn't cause permanent damage, but in severe cases, it can lead to ulcers or sores if blood flow is severely restricted for long periods. 6. Associated conditions. It can occur on its own, primary Raynaud's, or be associated with other diseases like scleroderma, lupus, or rheumatoid arthritis, secondary Raynaud's. Frostbite. 1. Cause. Frostbite occurs when the skin and underlying tissues freeze due to prolonged exposure to cold temperatures, leading to cellular damage. 2. Symptoms. Frostbite progresses through several stages. Frostnip, the mildest form, where the skin turns red or pale and feels numb or tingly, but no permanent damage occurs. Superficial frostbite. The skin may become hard, waxy, or blistered, but deeper tissues are still unaffected. Deep frostbite. In severe cases, deep tissues freeze, leading to potential tissue death, necrosis, gangrene, and possible amputation. 3. Treatment. Frostbite requires immediate rewarming, often in a medical setting, and severe cases may necessitate surgical intervention. 4. Duration. The damage from frostbite can be permanent, particularly in severe cases. It can lead to long-term complications like nerve damage and chronic pain. 5. Risk. Severe frostbite can cause loss of limbs or fingers, scarring, and significant long-term disability. Key differences. Cause. Raynaud's is a circulatory issue caused by vasospasm, whereas frostbite is due to direct freezing of tissues. Duration and damage. Raynaud's episodes are usually temporary and reversible, while frostbite can lead to permanent tissue damage. Treatment. Raynaud's is managed by preventing attacks and warming the affected areas, whereas frostbite may require emergency medical intervention. Clinical differentiation between Raynaud's phenomenon and frostbite is essential because the two conditions require different management approaches. Here's how clinicians typically distinguish between them. Raynaud's phenomenon. 1. Patient history. Trigger. Raynaud's attacks are usually triggered by cold exposure or emotional stress, leading to characteristic color changes in the fingers, toes, or other extremities. Reversibility. Attacks are transient, with normal skin color returning when the patient warms up. Recurrent episodes. Raynaud's often has a recurrent pattern, with patients reporting similar episodes triggered by cold exposure over time. Associated conditions. In secondary Raynaud's, a patient may have a history of autoimmune diseases like scleroderma, lupus, or rheumatoid arthritis. 2. Physical examination. Phases of color changes. During an episode, affected areas typically show a sequence of color changes: white, pallor, blue, cyanosis, and red, rubor. This triphasic color change pattern is a hallmark of Raynaud's. Symmetry. Raynaud's often affects both hands or feet symmetrically, although it can start asymmetrically in some cases. Absence of tissue damage. In most cases, there is no tissue necrosis, ulceration, or gangrene unless the disease is severe and prolonged. 3. Other findings. Capillaroscopy. Nail-fold capillaroscopy can help differentiate primary from secondary Raynaud's. Abnormal capillary loops may suggest an underlying connective tissue disease. Frostbite. 1. Patient history. Prolonged cold exposure. Frostbite occurs after prolonged exposure to extreme cold. Unlike Raynaud's, it is not triggered by brief cold exposure, but by sustained freezing conditions. No immediate recovery. Patients with frostbite often do not recover sensation or color in the affected areas quickly after rewarming. Pain and numbness. Frostbite patients typically describe severe pain or numbness that persists after initial rewarming. 2. Physical examination. Frozen tissue. In frostbite, the skin and underlying tissues may feel hard or frozen to the touch. Blistering. Superficial frostbite often presents with clear or blood-filled blisters that appear after rewarming. Blackened tissue. Necrosis. In severe cases, the tissue may become black and necrotic, indicating deep frostbite. Asymmetry. Frostbite can be asymmetric, depending on which parts of the body were exposed to the cold. 3. Other findings. Delayed symptoms. Symptoms of frostbite may evolve over time, with tissue damage becoming apparent hours to days after rewarming. Imaging. Imaging such as MRI or bone scans may be used in severe frostbite to assess the extent of tissue damage. Key differentiating points. Onset. Raynaud's is triggered by brief exposure to cold or stress, while frostbite results from prolonged exposure to extreme cold. Symptoms. Raynaud's involves a sequence of color changes, white, blue, red, while frostbite involves numbness, hard skin, blisters, and possible necrosis. Reversibility. Raynaud's episodes are usually reversible, while frostbite can result in permanent tissue damage. Associated conditions. Raynaud's can be linked to autoimmune diseases, while frostbite is a consequence of environmental exposure. Raynaud's phenomenon and frostbite are distinct in terms of their underlying mechanisms and classification, so it would not be accurate to classify Raynaud's as purely a pathology and frostbite as purely a physiological response. Here's why. Raynaud's phenomenon. Pathology. Raynaud's is considered a pathological condition, especially when it is secondary to other diseases, e.g. scleroderma, lupus. It involves abnormal vasospasm, which is an excessive narrowing of blood vessels in response to cold or stress. In Raynaud's, this response is exaggerated and dysregulated, leading to the characteristic color changes, pain, and potential complications like ulcers or tissue damage. The abnormal vasospasm seen in Raynaud's can be considered a pathological process because it deviates from normal physiological responses to cold or stress. Primary versus secondary. Primary Raynaud's can be seen as less severe, often not associated with underlying diseases, but it still represents a deviation from normal physiological responses. Secondary Raynaud's is clearly pathological, as it occurs in the context of systemic diseases. Frostbite, pathological condition, not purely physiological. Frostbite is not just a physiological response. It is a form of tissue injury and damage caused by prolonged exposure to cold. While initial responses to cold, such as vasoconstriction and shivering, are normal physiological mechanisms aimed at preserving core body temperature, frostbite represents the point at which these responses fail and tissue begins to freeze, leading to cellular damage, necrosis, and potential loss of limbs. Progression to pathology. Frostbite begins with physiological responses, like vasoconstriction, but as exposure continues and tissues freeze, it transitions into a pathological state. Damage at this stage is not a normal physiological reaction, but a harmful process that requires medical intervention. Summary. Raynaud's phenomenon, pathological condition involving abnormal vascular responses to cold or stress, often associated with underlying diseases. Frostbite starts with normal physiological responses to cold, but progresses to a pathological condition when tissue freezing and damage occur. In short, both Raynaud's and frostbite involve pathological processes, with Raynaud's being an abnormal vascular response and frostbite being tissue injury due to extreme cold. Neither condition can be purely considered physiological. Yes, both Raynaud's phenomenon and frostbite can occur in the same person. While the two conditions have different underlying mechanisms, they both involve abnormal responses to cold exposure, making it possible for an individual to experience both, especially under specific circumstances. Here's how. Link between Raynaud's phenomenon and frostbite. 1. Increased risk of frostbite in Raynaud's patients. People with Raynaud's phenomenon have an exaggerated vasoconstrictive response to cold, which limits blood flow to the extremities, e.g. fingers, toes. This decreased blood flow makes their tissues more vulnerable to cold injury. In extreme cold conditions, a person with Raynaud's is at higher risk for developing frostbite because their extremities are already receiving less blood flow, leading to faster tissue freezing and damage. 2. Post-frostbite Raynaud's. Conversely, a person who has previously experienced frostbite may develop secondary Raynaud's phenomenon as a complication. Frostbite can cause long-term damage to blood vessels, nerves, and tissues, leading to a predisposition to vasospasm. This can result in Raynaud's-like symptoms, where even mild cold exposure triggers abnormal vasoconstriction. 3. Compounded effects. In some cases, the presence of Raynaud's can delay the recognition of frostbite because the numbness and color changes associated with Raynaud's might mask early frostbite symptoms. This could increase the risk of severe frostbite if exposure continues. Clinical considerations. Diagnosis and history. Clinicians need to take a thorough history when evaluating patients with Raynaud's to assess their risk for frostbite, especially if they live in or travel to cold climates. Management. Preventive measures should be emphasized in people with Raynaud's to avoid frostbite, such as wearing appropriate warm clothing, avoiding prolonged exposure to extreme cold, and managing Raynaud's attacks effectively. In summary, while Raynaud's and frostbite are different conditions, they can co-occur in the same person, and each can influence the risk and severity of the other. Raynaud's phenomenon can be classified into two main categories: Raynaud's disease, primary Raynaud's, and Raynaud's syndrome, secondary Raynaud's. These terms reflect different underlying causes, clinical presentations, and management approaches. 1. Raynaud's disease, primary Raynaud's. Cause: idiopathic. The exact cause of primary Raynaud's is unknown, but it is thought to involve hyperactivation of the sympathetic nervous system, leading to exaggerated vasoconstriction in response to cold or stress. No associated diseases. It occurs independently without being linked to any other underlying disease or condition. Clinical picture. Younger onset. Primary Raynaud's often begins in younger individuals, typically before the age of 30. Symmetrical involvement. Symptoms usually affect both hands or both feet symmetrically. Classic color changes. Episodes are characterized by the typical sequence of color changes: white, pallor, due to reduced blood flow, blue, cyanosis, due to oxygen depletion, and red, hyperemia, as blood flow returns. Less severe. Symptoms are generally milder compared to secondary Raynaud's, and tissue damage is rare. No ulcers or necrosis. Primary Raynaud's does not usually lead to complications like ulcers, sores, or tissue necrosis. Management. Lifestyle modifications, avoidance of cold exposure, stress reduction, and wearing warm clothing are key preventive measures. Medications. Calcium channel blockers, e.g. nifedipine, are often used to reduce the frequency and severity of attacks. Other vasodilators or antiplatelet agents may be used in more severe cases. Prognosis. The condition is usually benign, with a good prognosis and limited complications. 2. Raynaud syndrome, secondary Raynaud's. Cause? Associated with other diseases. Secondary Raynaud's is usually associated with underlying connective tissue diseases or systemic conditions, such as systemic sclerosis, scleroderma, lupus, SLE, rheumatoid arthritis, Sjogren's syndrome, vasculitis. Other causes. It can also be secondary to conditions such as thoracic outlet syndrome, repetitive trauma, certain medications, e.g. beta blockers, chemotherapy agents, and occupational factors, e.g. vibrating tools. Clinical picture. Later onset. Secondary Raynaud's often appears later in life, after the age of 30. Asymmetrical involvement. Symptoms may be asymmetrical and often more severe. Complications. Secondary Raynaud's is more likely to cause complications, such as digital ulcers. Painful sores may develop on the fingers or toes due to prolonged lack of blood flow. Gangrene. In severe cases, tissue necrosis and gangrene may occur, leading to the risk of amputation. Worse prognosis. The prognosis is more guarded due to the underlying systemic disease and the risk of complications. Management. Treating the underlying condition. The primary focus in secondary Raynaud's is managing the underlying disease, e.g. systemic sclerosis, lupus, to reduce the frequency and severity of attacks. Medications. Similar to primary Raynaud's, Calcium channel blockers are often used. However, additional treatments may be needed depending on the severity, including endothelin receptor antagonists, e.g., bosentan, to prevent digital ulcers in scleroderma, prostacyclin analogs, e.g., iloprost, for severe cases. Surgical interventions in cases of severe refractory Raynaud's with complications. Procedures like digital sympathectomy, cutting the sympathetic nerves, may be considered. Close monitoring. Regular follow up is crucial to monitor for complications and adjust treatment as necessary. Key differences between Raynaud's disease and Raynaud's syndrome. Aspect: Raynaud's disease, primary Raynaud's. Raynaud's syndrome, secondary Raynaud's disease. Cause: idiopathic, no underlying disease. Associated with systemic diseases, e.g., scleroderma, lupus. Onset: younger age, typically 30. Later age, often 30. Symmetry: symmetrical, both hands, feet affected equally, often asymmetrical. Severity: milder symptoms, rare complications. More severe symptoms, higher risk of complications, ulcers, necrosis. Complications: rare, no ulcers or tissue damage. Common: ulcers, gangrene, tissue necrosis. Management: focus on lifestyle modifications and symptom relief. Treat underlying disease, manage complications. Prognosis: generally benign, good prognosis, more guarded prognosis due to underlying systemic disease. Understanding these differences is important for accurate diagnosis, appropriate management, and patient counseling. Yes, Raynaud's phenomenon can precede the onset of an underlying connective tissue disease, and this can indeed lead to a situation where a patient is initially diagnosed with primary Raynaud's disease, when in fact they may later develop secondary Raynaud's syndrome, as part of a systemic condition. This makes distinguishing between primary and secondary Raynaud's challenging, especially early in the disease course. Why this happens? Latency between Raynaud's and connective tissue disease. In many cases, Raynaud's phenomenon can be the first symptom of an underlying connective tissue disease, occurring months or even years before the full clinical picture of the systemic disease becomes apparent. For instance, Raynaud's may be an early manifestation of systemic sclerosis, lupus, or mixed connective tissue disease. During this latency period, if no other symptoms or signs of systemic disease are present, the patient may be diagnosed with primary Raynaud's. 2. Misdiagnosis as primary Raynaud's. Because primary Raynaud's is idiopathic and unassociated with systemic disease, it can be difficult to differentiate from early secondary Raynaud's, especially if there are no clear systemic symptoms at the time of presentation. Patients with subtle or slowly developing connective tissue diseases may initially be misclassified as having primary Raynaud's, only to be re-diagnosed later when the underlying disease becomes evident. 3. Diagnostic challenges. Absence of early systemic signs. Early in the disease process, there may be no clinical or laboratory markers of the underlying connective tissue disease, making it hard to establish a secondary cause. Nail fold capillaroscopy. This is a useful tool in helping to identify early signs of connective tissue disease. Abnormal capillary patterns, such as dilated loops or capillary dropout, can suggest that the Raynaud's is secondary even before other systemic symptoms appear. Serologic testing. Testing for antinuclear antibodies, ANA, and other specific autoantibodies, e.g., anti-SL70, anti-centromere, anti-RNP, can sometimes reveal early autoimmune activity before clinical symptoms of a connective tissue disease develop. Clinical approach to prevent misdiagnosis. 1. Close monitoring. Patients diagnosed with primary Raynaud's should be closely followed over time, particularly if there are any atypical features, e.g., asymmetric symptoms, severe attacks, or any signs of skin changes or ulceration. Regular reassessment is key to catching the development of any systemic disease early. 2. Baseline testing. Even if a patient presents with typical primary Raynaud's, some clinicians may consider baseline testing for autoantibodies and nail fold capillaroscopy, especially in patients with a family history of autoimmune disease or other subtle symptoms. 3. Red flags for secondary Raynaud's. Onset after age 30. severe or rapidly progressing symptoms, presence of digital ulcers or pitting scars, asymmetrical involvement, other signs or symptoms suggestive of systemic disease, such as joint pain, skin thickening, or muscle weakness. Reclassification over time. If a patient originally diagnosed with primary Raynaud's develops signs of an underlying connective tissue disease, e.g., systemic sclerosis, lupus, the diagnosis would be reclassified as secondary Raynaud's. This reclassification would alter the management approach, with a stronger focus on treating the underlying disease to control Raynaud's symptoms and prevent complications. Conclusion. Raynaud's phenomenon can indeed precede the clinical manifestation of a connective tissue disease, leading to a potential initial misdiagnosis of primary Raynaud's. Therefore, clinicians should remain vigilant and continue to monitor patients over time, especially if there are any features that could suggest secondary Raynaud's, to ensure that the correct diagnosis and treatment are eventually provided.